Hi, this is Brian Kim. I want to share with you episode number 3 in the From Good to Great series. And this particular episode is going to be about prepping and draping. And so meticulous betadine prep and draping is so important to have a great outcome because you don't want infection. And where does infection come from? Typically from the eyelash flora. And so when you look at the prep and drape that we do here with my staff and my techs, it's all about isolating and prepping the lashes. So this is a patient. We're going to put some proparacaine drops in. And once the eye is anesthetized, betadine is going to go in. That's 5% betadine going to go into the eye. You need to prep the eye directly first. And there was multiple drops of betadine in the pre-op area. And now you can see meticulous and aggressive scrubbing of the eyelashes is very important to remove any potential debris and that bacterial flora off the lashes and the lash line. And now you can see this is very generous prep placed all over the surface of the face, the eye area, the orbit, the eyelashes, and you want to do multiple rounds of this as well. Again, you don't want to have infection when you're doing cataract surgery, any eye surgery. And so prepping and killing any bacteria on the ocular surface, around the lashes, around the orbit and face is really important to help get the best result. And so that was a case just to illustrate the prep. And now here is the actual draping. You see the lid is retracted with the upper lid using the pinky, and then the Tegaderm is placed over the eye, but you can see how much overlap there is. The Tegaderm is actually more central and is covering quite a bit more than just at the lid margin. And so that was performed rather quickly, but you can see there's complete isolation of the lashes from the surgical field. So I wanted to show this again in half speed. This is very important to be able to illustrate this. So you can see there's a fenestrated drape, and then there's a half Tegaderm here. And she's going to use her pinky to retract the lid all the way upward. She's placing the Tegaderm right over the eye from canthus to canthus. That's very important. And then you see how the lashes have been isolated. Because it's going from canthus to canthus, you're going to have complete coverage of the lid and the lashes and all of the skin around the face. She retracts the lower lid and then places the Tegaderm in similar fashion, again, going from canthus to canthus. And so what does this accomplish? You can see there's quite a bit of overlap of the Tegaderm, and it's actually going into the field, but that's okay. I'm going to use the speculum to retract the Tegaderm as well as the lash line and the lids. You want to get under the Tegaderm as you do this. And we found that using the Tegaderm drape is probably the best way to minimize any corneal abrasions or corneal trauma during the draping. And then we put another drop of betadine after the speculum goes in, and put the betadine in and hold it there for a few seconds and then irrigate it out. And so we're showing the beginning of the case. I'm not going to show the entire case here, but the point is pay attention to the lashes again and the lid. You can see the Tegaderm is completely covering any skin, any lid, eyelashes, any part of the face around the surgical field is completely covered. She's going to use a pinky to retract the upper lid. She's applying the Tegaderm from canthus to canthus. And then she's going to do the same thing in similar fashion, retracting the lower lid, but she's using a two-handed technique with the lower lid. By doing it that way, she has complete control of the lid because the patients can have a tendency to squeeze and move around, and she has complete control of applying the Tegaderm, again, from canthus to canthus this way. So again, let's show that again in half speed. She has, again, the tegaderm cut in half. This is a patient who is a little bit kind of a blepharospasm, squeezing during the entire case. You'll see that later, but also squeezing during the draping. So she retracts the lid very confidently against the orbital rim. She carefully places the tegaderm on her finger, and she applies it and lays it from canthus to canthus, and she does that rolling maneuver of her finger. And by doing it that way, it doesn't disrupt where the tegaderm's already attached to the surface of the eye. She's kind of basically locking it into place and then rolling her pinky finger out of the way. If you just yank it and pull it away, it'll yank the tegaderm as well. And so that rolling maneuver is very important when you're doing the upper lids. And she did that again on the other left side as well. So here she's using her pointer finger, retracting the lower lid, but then she's going to use, you can see she's touching both sides, but that's okay. She has very good control. She's able to apply and then reapply based upon the patient. If they move or they squeeze, she can just lift it and put it back down again. But she's applying it again from canthus to canthus, from the nasal canthus all the way to the lateral canthus. And by doing it that way, you're getting complete coverage of the skin and the lashes and the lid margin. So she's retracting the lid just to make sure that the two tegaderm pieces are not stuck together. And you can see here now I'm just pulling off that last remnant of the paper from the tegaderm with some forceps. And then with this one, I'm going to show the entire case here. So again, this patient has a strong Bell's reflex. You can see the patient was squeezing quite a bit during the draping, but because of her excellent technique, and again, forcefully retracting the lids against the orbital rim, she had exquisite control during the drape. There was no sudden retraction or pulling down of the lids, and then the lashes are not covered with a tegaderm. That can happen if you don't have very good control with some of these patients. This patient has quite a bit of a Bell's reflex. We're trying to in a controlled manner, try to make our incisions, putting intracameral lidocaine and then epinephrine, some viscoelastic. Again, this patient has quite a bit of a strong Bell's reflex, and I'm asking the patient to look down. I'm holding the eye with the cannula and keeping in position after viscoelastic's put in to do the triplanar corneal incision. And I'm using that cannula, which helps protect the eye from rolling all the way up with the Bell's reflex. Holding that cannula in place, it's again right against the orbital rim. I have exquisite control. The eye is nice and straight, and now I'm able to do the capsulorhexis. Again, you saw my video from the previous, from good to great #1, where I talk about positioning the patient's head and rotating and tilting it in such a way that I have excellent visibility of the ocular surface and the eye. You want to make sure that the sclera has equal exposure from the limbus to the lid margin on both sides. That makes sure you're nice and straight and nice and up and down. And you can see that in this case as well, I have great exposure. And even though this patient's fighting me a little bit, I'm able to, again, perform the surgery. You saw the hydrodissection wave, and then now I'm spinning the lens. Again, this patient's moving quite a bit, having some trouble keeping the eye nice and straight, but everything's going well so far. And now I have two instruments in the eye, start to remove the surface epinuclear material, place the chopper under the rhexis edge, tilting it vertically, the phaco tip vertically subincisionally, fracturing the lens completely in half. And this is a pretty dense lens, probably around a 2 to 3 plus, placing the chopper around the right heminucleus, fracturing against the phaco tip like a chopping block, and that fractures the right heminucleus. Doing the same maneuver, lifting that first quadrant up a little bit, again, getting the instruments around it, crushing the lens with the chopper against the phaco tip, and then I'm emulsifying that first quadrant up. Again, moving and separating that second quadrant from the rest of the lens, getting the chopper around it, crushing it against the phaco tip, fracturing it into smaller pieces. And by fracturing it into smaller pieces, I'm utilizing less ultrasonic energy and using mechanical forces as a result. And now I'm spinning that second heminucleus in front of me, placing the chopper around the lens, getting out to the equator, pulling it central toward the phaco tip, fracturing the lens against the phaco tip. Doing the same maneuver for that third quadrant, again, fracturing the lens into smaller pieces, and then emulsifying the lens pieces. Again, I'm using the least amount of ultrasonic energy that I have to with this technique, positioning the chopper around the fourth quadrant. it turned a little bit, so I used some vacuum to grab it, lift it up, and then I crushed the lens between the instruments and then emulsified the lens pieces. So again, this is a fairly dense lens, maybe a 2 to 3 plus dense lens, and you can see the CDE is still around 2-ish. And again, maximizing mechanical fracturing forces breaks down the lens, so you have to use less ultrasonic energy and vacuum with this technique. Now I'm starting to remove the epinuclear material, keeping the chopper deep in the bag. So I take the chopper out, push BSS in, take the phaco tip out, go in with the ironing handpiece. I start to remove the cortical material from anterior to posterior, peeling off that material in such a way that it pulls off cleanly. If you don't do it that way and you grab it wherever, you're going to have a lot more fine cortical debris and wisps that are left behind, and that of course can cause PCO and more inflammation. So you want to get rid of all that stuff if you can. So I switched to polish mode, polishing underneath the rhexis edge. I grabbed the little chunk of cortex as it came out. I love polish mode because I can confidently polish deep into the capsular bag and the periphery. You know, these old cases, when you look on their videos, when I've done IOL exchanges, you see these giant Summerings rings. And that's because the surgeon at the time didn't do a thorough cleanup of the capsular bag. And I'm pretty convinced of that. And, you know, unfortunately back then, the microscopes weren't as good, instrumentation wasn't as good. And so the attitude was kind of like, you know, get the cataract out and get out of Dodge. And, you know, and that's fine because you don't want to have a complication, especially if you're not comfortable going after lens pieces that are deep into the capsular bag. But, you know, that get out of Dodge mentality has caused a lot of people to have Summerings ring, these giant pieces of lens material. And so I do meticulous capsular bag cleanup. I polish with the polymer tip. I pulse it to the subincisional space with the BSS. And then finally, I use a sweep to polish under the rhexis edge. You want to polish underneath the rhexis edge, but in the subincisional area, I do polish a little bit deeper because I know sometimes you can have lens material that's hiding in that space. Of course, you can do bimanual as well, but again, you'd have to switch instruments and so forth. So it takes a little bit more time. And so again, there's no right or wrong, but the point is trying to have meticulous bag cleanup is very important to help reduce the risk of having that Summerings ring. So I widen my incision and I go in with the 3-piece acrylic lens. I'm going to deliver the lens haptic, the leading haptic into the capsular bag. But before I do that, I push some more viscoelastic to fill the capsular bag because as I widen the incision and I push the injector in, you saw there was a little bit of collapse of the chamber there. I go in, bevel to the left, the leading haptic goes in, I rotate the barrel counterclockwise, the optic comes out planar, and then I use a Maltzman to dial the trailing haptic into the bag. I go in with irrigation off, activate irrigation, go underneath the lens here, removing all the viscoelastic from within the bag. Switching to polish mode and polishing the posterior capsule a little bit more, and then polishing underneath the rhexis edge. And then I'll hydrate my incisions. So again, I showed you first prepping, again, meticulous prepping. Make sure you put Betadine on the eye, prep the lashes aggressively. You want to get all of that material, the dead skin on the lashes and the lid margin. You want to exfoliate that stuff as much as possible, remove any bacteria and decrease the bacterial load on the lid and lashes. Retracting the lid against the orbital rim, the upper and then the lower. Again, using a rolling finger technique in order to be able to keep that Tegaderm in the proper position, going from nasal canthus to lateral canthus, canthus to canthus to get good coverage of the skin, first on the upper and then the lower, and then there's total coverage of the skin. And then when you apply that speculum, you're not only retracting the lid, but you're retracting the Tegaderm as well, which is again more central on the field than the lid margin. So therefore, you're not getting any of that lid margin exposed in the field. You saw with each of those cases, there was excellent exposure. Again, the lid margin is out of the way. And because I had proper head position, as I've shown on episode number 1. This patient had perfect symmetry, alignment, parallax, and this is the way, in my opinion, that you can go from good to great with your prepping and draping of your surgical patient. So I hope this was helpful to you, and I thank you for your attention.